just going to continue on. I'm just going to speak, and then Mike, and we'll have a question and answer session at the end.
For those who would stay, not question and answer, a discussion. I think it would be much better to have a discussion rather than view us as any sort of expert, because clearly I am not an expert on Jersey, having my first visit to this incredibly beautiful place, and I only arrived yesterday. So I know nothing about that. I do know a little bit about general practice as the foundation of a socially responsible healthcare system, on the other hand. Now, just a tiny bit of history. This crucial division between general practitioners and specialists that we see in the UK, and we see actually it's been recreated to a greater or lesser extent right across the world, is a gift of history. And it happened almost by accident in England, between these dates, between the Apothecaries Act of 1815 and the Medical Act of 1858. And it was in that period that the specialists, always with an eye to the main chance, took control of the newly built modern hospitals that all appeared in the major cities in the 19th century. General practitioners were excluded from the hospitals, and the principle of referral was created. And as a result of that, the physician and the surgeon retained the hospital, but the general practitioner retained the patient. And that has been the key to the success of general practice. And after that date, in hospitals and universities, specialists began their ever more detailed elaboration of biomedical science, slowly constructing taxonomies and unravelling etiologies and experimenting with various modalities of treatment. And all this has brought enormous technical advances, increasingly effective treatments, and much relief of suffering. But meanwhile, general practitioners, and perhaps nowhere more so than in Jersey, remained close to their patients, close to their communities, and were able to observe the progression of illness and disease within particular life contexts and stories. They saw disease affecting a unique succession of individuals and came to understand the extent to which individuality modulates disease, so that no two individuals ever experience either illness or disease in the same way. A phenomenon that the quite remarkable Leo Tolstoy describes so well in War and Peace, when he writes, "No complaint affecting a living being can ever be entirely familiar, for each living being has his own individual peculiarities, and whatever his disease, it must necessarily be peculiar to himself, a new and complex malady unknown to medicine." So general practitioners developed a rich understanding of the inconsistent relationship between symptomatic illness and biomedical disease, between suffering and pathology. And then whenever patients were referred to specialist colleagues, these patients would usually return to their general practitioner and recount their experiences of specialist and hospital care. And as a result, as biomedicine made its advances, general practitioners became more and more aware of the power of scientific medicine for both good and harm, more aware of the dangers as well as the benefits, and as a direct result they developed a cautious, parsimonious approach to investigation, diagnosis and referral. Now these almost certainly contribute to explaining the findings of Barbara Starfield and her team at Johns Hopkins University in the United States, her finding consistent across all sorts of different settings that a strong system of primary care produces better health outcomes at lower cost and with less health inequity. And the division between specialists and generalists seems to have helped both to thrive. And during the second half of the 20th century, the British model of general practitioner care was adopted across many other healthcare systems. And there's still enormous international interest in that system. Of course, it remains to be seen whether that interest and the prestige it brings with it can survive our current government's enthusiasm for chaos and their determination to reorganise care in the UK, in England, yet again. and open it up to the predations of commercial profit. There are also worrying signs that in the UK that we're beginning to follow the global trends that are tipping the balance of provision away from primary care and general practice and towards hospitals and specialists. And in 2010, all general practitioners, including those still in training, represented only 27% of all doctors in the National Health Service, and that's an all-time low. And I'd like to learn where Jersey stands in terms of that crucial balance. And this matters because Barbara Starfield's findings suggest that a relative increase in the number of specialists leads to an increase in mortality. And why might that happen when specialists have knowledge, skill, and immense dedication? Why might that be so? And the problem seems to be much to do with the desire to do good with the tools available. Because medicine is dangerous. You must always remember that medicine is dangerous. It's occasionally brilliantly effective. It's often helpful. It's sometimes disappointing. And too often, it's actively damaging. Surgeons provide the easiest example. And this is a quotation from Jack Wenberg from the Dartmouth Medical School in Massachusetts. Few surgeons are hesitant believers in the efficacy of the operations they perform, nor do they doubt their clinical necessity. Most patients are convinced that the benefits of surgery exceed the risks by a wide margin. But in the face of such certainty and conviction, it is remarkable how much medical opinion on the need for surgery can vary from place to place, and how much uncertainty there is concerning what risks and benefits are and what treatments patients actually want. So we're getting pretty close to the nub here. And Jack Wenberg, in this article, paid tribute to this guy, this is the only blurry photograph of this man who exists. I'm sure none of you can name him, but he is James Allison Glover. And getting on for 100 years ago, he drew attention to the very rapid rise in the frequency of tonsillectomy. Now, you may think that this is historical and irrelevant, but this sort of pattern is repeated over and over again. And he noticed the enormous variation in the rate of operation across the different school districts of England. A child living in Bexhill would seem to enjoy climatic and cultural advantages at least equal to those of Birkenhead, yet he is 27 times more likely to be submitted to the operation. Now, Glover could find no explanation for this in terms of need, and correctly attributed it to the beliefs and behaviours of different surgeons. And Starfield reminds us that none of this is benign. Between 1931 and 1935, 424 school children in England and Wales died following tonsillectomy. In the context of general practice, each death represents a devastated family with repercussions lasting years. No wonder general practitioners are so clear about the potential harm of medical intervention and have a tendency to be sceptical of received wisdom. Good intentions continue to drive variations in the rate of intervention. The optimal level of, for example, caesarean section, or spinal surgery for back pain, or MRI scanning for headache, is very difficult to establish. However, not surprisingly, the number of specialists available is directly associated with the number of interventions. More specialists means more interventions, both diagnostic and therapeutic, especially in systems that actively reward intervention through payment for performance. More intervention implies both costs to the healthcare system and the possibility of profit for someone, but it is not necessarily a good thing. And today we see the seductive possibility of preventing disease, ratcheting up good intentions and the wishful thinking which too often underpins them. This is an extraordinary book, and as Iona Lowery, the author of this book, writes, professional and lay understanding of cancer was and continues to be shaped by the aspiration of identifying and eliminating cancerous lesions, precancerous lesions. The extraordinary viability of this idea reflects its plausibility, its ability to address well-entrenched fears, and its capacity to channel activities of multiple constituencies. It also points to risks of excessive simplification of complex phenomena. The evidence is now overwhelming that cancer screening causes significant harm through overdiagnosis and the stress and sequelae of false positives. And yet this harm is caused by good doctors striving to prevent people from succumbing to horrible diseases. Doctors and patients collude in obscuring the problems of overdiagnosis, preferring to present patients as having been saved from cancer. And the whole messy situation is compounded by the fact that overdiagnosis leads directly to improved survival figures, which are much appreciated by clinicians and policy alike, while leaving mortality rates completely unchanged. If you increase your denominator, if you diagnose things that were never going to turn into cancer, your survival rate miraculously improves. That's why you should never judge any intervention on survival rates, any screening intervention on survival rates. It has to be on mortality rates. Okay, now, whose is it? Who's the guilty party? It's all right, it's off now. This is my diagram. This is how, for many years, I've made sense of what I try to do. And it's been widely criticised by sociologists that you can't represent human life with rectangles. I'm reliably informed. But it makes sense to me. Now, I'm trying to use this to show the importance that general practitioners attach to scrutinising the red line, this line between illness and disease. Because stressful life experience and illness symptoms flux all the time. You can get a headache because you drank too much the night before, because you had a row with your teenage child, because you've got a brain tumour. You can get a headache. It's very important that we don't misdiagnose either the brain tumour, but equally we don't heavily investigate somebody who has a headache because they're in a stressful life situation. The demise of a religious and philosophical explanation for the arbitrariness of human suffering has left the modern world with limited ways of understanding and coping. And illness is now one of the few valid outlets for human distress. But if we wrongly interpret such illness as disease, all kinds of damage can be done. And general practitioners have learnt from experience, and this is the huge contribution they make to healthcare systems. They've learned from experience to both the benefit to both the individual and society of holding that border between subjective illness and the disease categories recognised by biomedical science, of confining people within those categories only when such labelling will be positively useful to them, and of deliberately minimising exposure to the harms of medical technology. So in this way we attempt to direct both the power and the rising costs of biomedical science where it can help rather than where it harms. And so holding that border underwrites the cost effectiveness of a health service to a far greater extent than gatekeeping at the point of referral. And this is the real worry about the Jersey situation, where there's an incentive, because you have to pay a fee to, I understand, to see a primary care doctor in Jersey, and you can go to A&E free, then you bypass this enormous opportunity that general practitioners offer a healthcare system of holding that borderline, and the extraordinarily close connection that Jersey GPs have built up with their patient population, because it's a small community, because you're here, because you have such high levels of continuity of care, means that levels of trust are high, and that levels of trust make it so much easier to hold this border effectively. This is just a little diagram that shows the positive predictive value for any test, question in the history, a blood test, anything, depending on the prevalence. You'll all have learned this, but I had long since forgotten. so that you can have the same sensitivity and specificity in a population at 20% with 20% prevalence, and you've got a 96.1 positive predictive factor in a prevalence of 0.1, it's 9. That's a useless positive predictive value. So another thing that general practitioners do is it's a wonder we ever get it right with these sorts of positive predictive values, but we do. The miracle is we get it as right as often as we do, not that we occasionally get it wrong. But what we do is, for our specialist colleagues, we very kindly select them a high prevalence population, so their investigations work robustly. This is a gift from primary care to specialists, and it would be nice if it was a little more understood and appreciated. The trajectory of the patient, however good their medical care, will always eventually end in death. And here again, the experience of specialists and general practitioners diverges. Last year, I despaired of the prevailing talk of an epidemic of non-communicable diseases and tried to ask the medical community what they wanted to die from and whether they'd prefer to go back to dying from accidents and infections. People were very reluctant to answer this question. But I received a very wise response from a specialist, and he wrote, "We as consumers and providers of healthcare know all too well about the certainty of death. We pretend and lead our lives trying to ignore this inevitability. And it is becoming easier to do so. We concentrate on one cause of morbidity, devise dubious early diagnoses, tout treatments focusing on proxy measures, and set aside competing comorbidities. We have come to believe, either sincerely or otherwise, that deaths from causes outside our own dedication or specialty is tantamount to success and mission accomplished. We know better, but the material rewards are generous for ignoring the whole human condition. Diverting attention towards minor gains is rather enriching." So a death from a non-cardiac cause can be regarded as a triumph for a cardiologist, but all deaths fall within the remit of the general practitioner, and both specialists and generalists need perhaps to look a little more honestly at the effects of these postures of denial on those we care for and on society in general. So we've achieved something precious in the British healthcare system. We have a single but dualistic profession with common initial training, equal status, and useful reserves of mutual respect. Specialists and general practitioners are inextricably dependent on each other's skills, and crucially, most are keenly aware of that interdependency. General practitioners can only work to the limits of their skill and knowledge if they can refer easily and promptly to their specialist colleagues when these limits are reached. And specialists can use their skills maximally only if they're enabled to work with a highly selected population for whom their particular skills are appropriate. There's an almost perfect complementarity between the two parts of the profession. And anything that makes it difficult for general practitioners to refer, any sort of incentive against referral, which we're beginning to see in England, is dangerous for patients. Another thing which is dangerous for patients is payment by results. So in the latest rounds of manipulation of the NHS in England, from which I think Jersey has so far been spared, but I'm not entirely sure, so you'll be able to put me straight if I'm wrong, is the intention to substitute competition for cooperation in the relationship between specialists and generalists. So the specialists in the acute trusts are now working within a framework of incentives, so they get payment, so the more they do, the more they get paid, and at the same time, GPs are being financially induced to provide rigidly standardised care for those with certain chronic diseases, and then encouraged or coerced into undertaking commissioning, the intention of which is to keep patients away from hospitals. So you have the GPs who are supposed to be keeping them away from hospitals, specialists who are supposed to be sucking them in from hospital, and how are they supposed to be working collaboratively in the interest of individual patients? Most policymakers seem to have little understanding of the importance of personal relationships in healthcare. It may be different in Jersey in a small community. Relationships between doctors with different skills and between doctors and patients. Specialists and generalists have and will always have much to learn from each other, particularly if they're doing that learning around the predicament of a particularly individual patient. We have a responsibility to maintain and strengthen those relationships if policymakers aren't doing it for us. So this is Barbara Starfield. Strength of a country's primary care system, negatively associated with all-cause mortality, all-cause premature mortality, cause-specific premature mortality from asthma, bronchitis, da, 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 da. You would have thought that would get everybody in the entire world behind primary care. And we did have the WHO primary care now more than ever. You need the strongest possible system. This is the thing about them having. But this is the key. That Barbara's conclusion that the beneficial effects of primary care on mortality and morbidity can be attributed, at least in part, to the focus of primary care on the person rather than on the management of particular diseases. You have to keep, in specialist care, you're a specialist in a disease or a group of diseases. The disease will be in front of the patient, so the disease stays and the people come and go. In general practice, it's the reverse. And what has happened with the quality and outcome framework in the UK is that it brings the disease in front of the patient, even in primary care, so that you begin to talk about the diabetics. We didn't used to talk about the diabetics in primary care. We now do talk about the diabetics, because we have to get them all ticked off by the end of the year. That stops you tailoring care to that individual in front of you. That's the huge danger about doing things. And I think I'm going to stop there. Yeah? Enough already.